Halfway done class. Can you believe it? We're moving right along. So today we're going to be talking about some anxiety disorders and cognition changes due to age. Um, a lot of us are facing this as we know aging adults in our life. We see things like dementia, we see things like Alzheimer's. Um, Again, I can't stress this enough with any sort of client that you have that is noticing physical changes to their bodies, whether it means forgetfulness, maybe it's a sexual dysfunction, um, a sudden onset of some sort of delirium or psychosis or anything really. We always want to consult a doctor because we always want to rule out any sort of medical condition that could be causing the problem. One time, I'll tell you a therapist story. One time I was seeing a client who was, I would say probably at the time was maybe in her 60s, still driving, was actually caretaking a relative. And I noticed in session, as sessions continued, that her memory was terrible. Like it was very, very concerning, like repeating herself, constantly forgetting her appointments, needing to be reminded. Um, just talking about things from a very long time ago, but there was even a level of repetitiveness in the session of things that she was saying. She was just repeating them over and over. And I was concerned. And so I had to ask for her permission to speak with someone that she knew. And so she allowed for me to call her best friend because she didn't live with a partner, and she was taking care of an elderly person. And so I was able to talk to her relative, or not her relative, I'm sorry. I was able to talk to her best friend and I explained what had been going on. And what I found out in the midst of all of this that was going on too is she's had some rapid weight loss. And so I think what came about was through conversations with the friend, and then the friend encouraging her to go to the doctor or taking her to the doctor, that she was experiencing some level of dementia due to diabetes. And so you just never know what could be going on with someone. We're seeing one part of a picture in a bigger puzzle of life, right? Not to be too cheesy, but that is true. We're seeing one part. And so we need to not be afraid or intimidated to encourage clients, or if you're really concerned about something, to have them talk to somebody, because like a doctor, because it could be very concerning and problematic and not good for their overall well-being. So most of us experience several changes in memory. That could be depression can cause change in memory, anxiety can cause change in memory, age can cause change in memory, a busy season in life, where everything seems chaotic. I have 5 kids, 4 of which have an activity. So trying to keep track of practice schedules, work schedules, a birthday party thrown in the mix, something special that's happening. I mean, it's a juggling act, and so it's bound that something's going to get forgotten. That doesn't mean someone necessarily has a neurocognitive disorder. And so you have to take that into consideration, right? Some people are experiencing more severe memory things, like their cognitive impairments. They could like lose their memory while doing something familiar. Like, I don't know how to get back to my car, but it's something I do every day. Um, it's something that, maybe they lost their keys, but their keys are found in a very odd place. Especially when something should be familiar to someone and they're forgetting. That's when it's kind of like, these are little red flags of like, what else is going on here? Okay. Some people experience more severe memory thinking changes. And these could be more dramatic, things that really shouldn't be forgotten. It's pretty basic. And it's like none of those other factors are part of the issue. We're rolling out some things, and then we're realizing maybe we're in this place of there being an impairment. So what is delirium? Delirium is a disturbance in attention and awareness that develops over a short period of time. It's typically short-lived, so meaning not permanent. The person usually recovers, may fluctuate, usually caused by general medication conditions or substance intoxication or withdrawal. So somebody going through maybe a supervised withdrawal, medical condition, or medications maybe somebody is on. It's not something that, again, is permanent, something that will go away, but would cause some bizarre probably behavior or some bizarre things being said. Dementia, as we talk about it, and other neurocognitive disorders, dementia involves cognitive deficits. They're chronic, develop slowly, show a progressive course, so meaning it's going to continue, and usually irreversible. A major neurocognitive disorder involves significant cognitive decline. Your body shuts down, basically. It affects daily activities. Like at some point, probably somebody shouldn't drive anymore, or maybe be left alone to go do a task. A mild neurocognitive disorder involves modest cognitive decline, but without interference in daily activities. This is why we talk about people like making sure we're taking care of our brain health, challenging our brain, doing the word puzzles, especially after retirement. And there's a lot of sitting around. I'm not saying that's what causes dementia by any means, but these are things that help our brains, right, keep firing. Obviously, people need to go see a neurologist and talk to someone to see if they do have these conditions, what they can do. There's medications that can kind of slow the progress of the condition, but unfortunately, a lot of these more major illnesses, there's nothing that makes it reversed. Alzheimer's disease involves slow and irreversible progression of dementia. Symptoms may include aphasia, apraxia, agnosia, executive functioning deficits. We're seeing this in Bruce Willis right now. Started with some speech deficits, right? Things that I should know, but I can't do. Lewy body disease. I have a client right now dealing with that with their mom. Includes most of the key features of Alzheimer's disease, but may also include visual hallucinations, muscle tremors, and a more fluctuating course of symptoms. Sometimes there's like paranoia that's really bad. And people can become very much not like themselves. Some of you, unfortunately, have had to experience this with family members. People can become very cruel or mean, and maybe they were never like that prior, but they became like that because of the course of the disease. Parkinson's disease is a progressive neurological disorder marked by unusual movements that may lead to a neurocognitive disorder. Not everyone who gets Parkinson's necessarily will have dementia or things like that, but that can happen. Pick's disease is characterized mainly by disorientation in the frontal and temporal brain lobes. If you have a TBI or traumatic brain injury, this can cause some level of memory loss and or brain problems, neurological problems. So as you get older, the rate of delirium increases. I know with my grandfather, who was very sensitive to medication. So if he went into the hospital and was given any sort of pain medication, he was definitely in a state of delirium. I mean, bizarre things he was seeing, people talking to him, all these things that weren't happening, but it was like he was so sensitive to the medication. Rate of dementia increases with age, especially after the age of 80. Most older persons are still affected. Approximately 5% to 8.5% of people age 60 plus years have dementia. Approximately 2/3 of people with Alzheimer's disease are women, are age 75 plus. Which is like scary, right? And that's why it's important for us to take good care of ourselves. I think, knowing maybe genetic predispositions, what can you do to kind of alter that, all those kinds of things. Rate of dementia varies with culture, likely due to genetic, diagnostic, or cultural differences. General prevalence of vascular dementia is about 1.5%, rates higher for people ages 85 plus. Vascular dementia perhaps more common in African Americans. Prevalence of dementia due to Parkinson's disease is older than 65 years. Men and women show equal rates of dementia due to Parkinson's disease. Prevalence of the disease itself is more common among men than women, right? Epidemiology. I don't know why I'm having a hard time saying that word. That's so funny. Epidemiology of neurocognitive disorders. Frontotemporal demastesis, including Pick's disease, are showing in earlier stages, whereas neurocognitive disorders are highly comorbid with one another. So you got all these different kinds of things that could be coming up, like I mentioned, agitation, psychosis, apathy, aggression, that shutting down of that empathy part, that warm, nurturing part. That's why I'm saying a person who came off as this warm, nurturing, loving person, and then they have, unfortunately get diagnosed with dementia and Alzheimer's, and as the disease progresses, this side of this person comes out that was never this person, which can be very difficult, very hard, very painful for people. This is why people taking care of aging adults need support, need therapy, because you're pushed really to a limit, especially when patients, clients, people you're taking care of get paranoid and they're questioning you about everything and accusing you of stealing. And I'm not saying those things don't happen to people who are aging, but it can be almost traumatizing, right? Going through this with people. And the sad part is the person who's suffering doesn't even really realize what they're doing, right? They're unaware, totally unaware. And so it's just it's a frustrating process, and it can go on for a very long time. And so that's where people taking care of other people need to really be careful for themselves and take care of themselves and have good self-care, because it is a lot. It is a lot. So for many of you, you probably know people who are suffered, like I've mentioned, have gone through that walk of life yourselves, with a person you've had to care for, or have known maybe a grandma, grandpa, auntie, uncle, relative that have gone through something of this nature. Just like the slow progression of watching a person kind of dwindle away. And when we talk about the grieving process and how grief, like, when someone has kind of more of a terminal illness like this, the grieving process doesn't necessarily start with the diagnosis, but maybe starts as the person starts to fade away, because of the person that you once knew is not that person anymore, and you're able to recognize that quite clearly. And so, just being mindful of that. There's a lot of things that come up when dealing with aging adults in your office, and aging adults needs therapy too. Sometimes there's some cultural barriers just because it wasn't as comfortable during their time to go get help or talk to someone. But there's a lot to work through in this stage of life, between losing maybe some independence, not being able to do things the way you wanted to, that frustration. It can cause a lot of anger, resentment, maybe cause some conflict in the family. And so it's good. There's a lot of loneliness, depression that goes on in aging adults too. So being able to even be a support to aging adults is a direction you could go as a therapist. But these conditions are very hard. They're scary. And there's not a cure. So these are things that we're working towards in science and all that stuff. But if you know that there's a propensity for those kinds of things in your family, trying to take those proper steps will be helpful to maybe avoid having that same outcome. So talking about neurocognitive disorders, so let's talk about worry, fear, anxiety. You could be worried and fearful about those things too, because of your genetics. So worry, the cognitive concept that refers to concerns about possible future threat. We see this a lot in people. A book on my list to read is The Anxious Generation, talking about how anxiety has skyrocketed basically since the iPhone in our youth. And I think if you know any young people today, you hear them talk about their anxiety quite often, whether it be social anxiety post-COVID. They're anxious about everything. As we know, there's some level of anxiety that is healthy, right? There's anxiety that we get before a job interview, a test, something important in our lives, an exciting event, a race. But the level, like those things are normal. A first date, those things are normal. But then there's a level of anxiety that goes beyond that causes somatic symptoms, stomach aches, headaches, throwing up, depression, harm to self, can't leave the house, don't want to do anything. That's more debilitating. And so we have to kind of figure out, when we're talking with clients, what is that? What's the difference between something that's more on a basic level that everyone experiences and something that's more intense? Now, I think some stuff that we have to work through in our culture is, it's like I said, it's normal to be anxious. So just because you're anxious, that doesn't mean it's a bad thing. It's like a fight flight response. It tells you to be more concerned about something. It doesn't have to be horrible, right? It's just how we manage it that makes it problematic, right? So worry, like I mentioned, anxiety is an emotional state when a threatening event draws close, includes physical feelings, thoughts, and behaviors. Fear, intense emotional state that occurs as a threat is imminent or actually occurring. A lot of time our anxiety is, once you learn about cognitive behavioral therapy, our thoughts turn into our behaviors, which turn into our beliefs. So if our thought is, I think I'm going to die, then our behavior is more scared, anxious, worried, have a hard time making decisions. Maybe you don't want to leave and go somewhere new. And that belief then is, I'm going to die, right? This is the thing, like our irrational self takes over. A lot of times it's our heart, maybe not our head. Sometimes it can be vice versa. But we just live in a state of fear, which isn't good for us physically. It's not good for us mentally, and can be very debilitating. It minimizes the potential we could be. And, the extent to which they involve cognitions and feelings, like what's true, what's not true. And that's where we do cost benefit analysis. Is this costing you more than it's benefiting you? All that kind of thinking. What's a panic attack? Some of you may have experienced that. Panic attacks involve a period of time in which a person experiences intense feelings of fear, which then causes physical symptoms, not being able to breathe, heart racing, heat maybe. Some people get warm. Sometimes some people can feel like they're going to pass out. Sometimes they come on unexpectedly. Like I have clients that sometimes wake up with them. In the middle of the night. I have other people, they can sense them coming. Sometimes they're triggered by specific events or types of events, maybe because of trauma. And obviously not a great way to function in life. And so somebody could have a panic attack and work through it, maybe never have one again in their lives. Other people deal with them all the time. And so that's where we need to look at, like, why are we having them? How do we work through them? Can we sense them happening beforehand so we can maybe stop it before it starts? Those are the kinds of things we have to work through. A panic disorder is regular, unexpected panic attacks, at least one of these attacks followed by a month or more of concern about having another attack. A lot of times with anxious conditions, sometimes people with panic disorders may have something called agoraphobia. Maybe some of you have struggled with that also in your past. Agoraphobia is a situation that happens when you feel like you can't leave your home. You feel like it's unsafe, like you literally have a visceral reaction to the idea of leaving. We have a few clients at our office that have that issue. So we're seeing them virtually. Virtual therapy has worked out amazingly well. And probably a lot of great ways to get people help with some of these concerns, but also probably doesn't challenge people too, to some degree, because it's almost like we get to keep them in their environment. But still, I'm so glad that people can get help even when they are at home and they feel like they can't leave. So that is also a panic disorder, and happens for people. You probably have known someone in your life where this has happened. Specific phobias are, spiders, right? Some sort of natural environment, situational things like, for example, somebody might be fearful of flying. That kind of is a more of a process phobia, because you think of, like, you book the trip, you pack your suitcase, you get to the airport, you check your bag, you go through security, then you have to get on the plane, then they shut the door, which usually really kind of triggers people, and then you take off and, So there's a lot of great different treatments for that. EMDR is great for agoraphobia. I'm sorry, for traveling phobia, process phobia, and also for specific phobia. You can have a phobia over all kinds of things. Some people have a phobia of throwing up. That's kind of a popular thing right now with young people. And so they're very fearful of the food that they eat, that it might cause them to vomit, all those kinds of things. Unpleasant, but a thing. General anxiety disorder, this is diagnosed a lot. So worry is over the top, and more so than what the situation should have. Trouble sleeping, trouble eating. They can't control their thoughts. Obsessive compulsive disorder, there is two components to that. There's the obsessive portion and the compulsion portion. So common obsessions are containment, doubt, fear. Sometimes they have like stuff with God, like religion. In a sense, it's like a spiritual warfare constantly. Like, does this mean if I don't do this, am I going to go to hell? And it turns into this whole thing that it's not. And like, then they have to do rituals of some sort to get out of it. So that's where we see things like Mad About You. It's an old movie about OCD, but We'll see things like hand washing, touching things a certain number of times. I see a lot in women with the compulsions with their thoughts, like they can't stop them, the obsessive thoughts, and then what they have to do to get out of the thought. And then they feel like they have to apologize because I was thinking about this. And it's just, I have to say sorry. And if I don't say sorry, it's just this whole thing. Very exhausting for people, very tiresome for people. It can be treated with, of course, therapy, medication, all those kinds of things. So we talk about trichotillomania mania. That's when you're pulling your hair. You got hoarding disorders. We've seen that on TV, body dysmorphic disorders, preoccupied with how the body looks, and oftentimes a very tainted view of how the body is. PTSD, very common with people. PTSD can be kind of not necessarily just like war-like situations. If you feel like your life has been threatened in any kind of way, when you think a car accident, something that happened in a public event, maybe something specifically in a relationship that caused someone to be fearful, getting robbed. There is a fear usually though for your life, and it's marked by having nightmares, feeling like you're in that moment, intrusive thoughts. It alters your mood. And it's been going on for over a month. A lot of times people can go through a traumatic situation, and it won't stay with them, but for like 80% of people it won't stay. But for that other 20%, it gets really stuck. When we think of Route 91 that happened a while back, a lot of people were at that concert, a lot of people were at that event, and maybe about 80% of them weren't traumatized to the extent of PTSD, but then there was that 20%, it was really hard. We do treatment like EMDR for that, eye movement desensitization reprocessing. We're talking about the amygdala, that part in your brain holds memory. And, sometimes our memories can get stuck in a place they don't belong. And then every time you're triggered or every time something seems similar, you feel like you're in that same moment. And so EMDR, as strange as it sounds, helps you stay in its proper place. So PTSD is something that comes up quite often in the office. People have experienced very traumatic things in their life. And they get very stuck, and it can be very debilitating. Of course, veterans have gone through a lot of different things, being in a war situation or even going through training for war. And there's sometimes a lot of shame with that. And so there's a lot of great veteran services out there. Veterans tend to open up to other veterans, but that doesn't mean one won't open up to you. But there is help out there to get the best treatment possible. And so lots of great opportunities and things out there to help people, because why stay so trapped or stuck? I think it was American Sniper. Such a great movie talking about PTSD from a war situation. When we think of our first responders, police officers, firefighters, ambulance, people in an ambulance type situation, a lot of intense images and situations that come up that make you fearful, but then you're in this fight or flight mode because you are trying to rescue and trying to help, and you don't realize like your own life's in danger, So there's a lot of things that can come up with for people in different ways. Then they look at their own child, and then they have these images of maybe somebody else that they've seen, and it's just very traumatic. So things that you will definitely see, things that are coming up, look for them in your DSM. But I hope this lecture was helpful and just hitting some nails on the head. Maybe even looking into potential things you want to get trained in based on maybe even some of your own experiences. But EMDR is a great resource to get trained in. You will utilize it in therapy. A lot of these anxiety disorders, cognitive behavioral therapy is primarily what we use. Good stuff. So I hope you all have a great week. We are halfway done. Talk to you soon.